thank you so much for being here today. Welcome to the Hold My Hand webinar series. This series today is going to be co-hosted by CHI, the Clinton Health Access Initiative, and Side by Side, the National Department of Health's health campaign that's targeted at children under the age of 5, ensuring that all young children receive nurturing care. So a few things about today's webinar. You will see that we have a sign language interpreter. And just a note, if you would like to read what is being said, please just reminding you to turn on your captions for this session, but also remember for all other digital communications or webinars or online calls, feel free to turn on your captions to read what is being said. On that note around reading, why don't we use the web chat to introduce ourselves? Please type in who you are, your name, your location, and maybe the role you play in young children's lives. Are you a caregiver? Are you a teacher? Are you a healthcare worker? Or do you work at an organization? Use the chat, let us know. It'd be lovely to know what brings you here today and who you are. So I'm part of the Hold My Hand team, and Hold My Hand is sending the message and really mobilizing the national strategy to accelerate action for children. So what this strategy is really is a strategy that focuses nationally on 10 key priorities that are important to ensure that every young person reaches their full potential. One of those key priorities is focusing on newborn hearing screening. And so it's September, it's Deaf Awareness Month, and we've actually just closed out International Deaf Awareness Week, and last week we had International Sign Day. So it's in keeping that this would be an important time to raise awareness to hearing loss, and particularly screening for hearing loss at a very young age. We believe that all children should be screened for newborn hearing loss. So how much of that do you know? Let's find out. How about a poll to see how much we know about newborn hearing screening? A couple of questions will come up. Let's see. Answer each one. There's only 3. The first one is around assessing the prevalence of hearing loss. So over 430 million people globally live with disabling hearing loss. In South Africa, how many children do you think per day are born with hearing loss? Second, which one is the most appropriate answer? Think through this one carefully. Who do you think should test or diagnose or screen for hearing? Should it be an audiologist? Should it be just to babies who are considered high risk for hearing loss? Should it only be if it's a referral from a healthcare worker? Or should it be all babies in their first month of their life? And lastly, what do you know about the actual process of newborn hearing screening? Is it pain-free? Is it quick? Is it safe? Is that true or false? We say it's pain-free, quick, and safe. Do you think this is true? Do you think this is false? Giving you a second just to complete your answers. And your results should come up shortly. So now that we've tested your knowledge, we see that there is still some room to learn. Some people know that it's about 17 children per day. It's great that most people might begin to know that all babies should be tested in their first month of life. And yes, it's true. It is pain-free, quick, and safe. So that's just a little knowledge quiz. There's lots more for us to dive in today. So I have a panel. Our special guest is actually a mom and her little baby, Abdullah Miles, and she's going to share her story today. Then we'll move into a little bit of the leadership, and we'll speak to a policy advocate and practitioner, the head of speech and audiology, Dr. Bolton. We also have an audiologist who's on the ground, who works in Mpumalanga, Mr. Sakile Nkosi. And then we'll have a representative from the National Department of Health, We'll speak to Dr. Busisiwe Ndlovu, who's the Director of Non-Communicable Diseases at the National Department. But there is also an important person, an important group of people whose voice needs to be heard today. And this is the platform we'd like to provide. Children. We believe they should be the center. So let's hear from a little girl who's experienced profound hearing loss.
It was discovered with newborn screening that I had bilateral deafness. When I was 9 months old, I had bilateral cochlear implants. After surgery, I learned to hear with my cochlears and speak, and now I attend a mainstream school and am one of the top students in my grade. Most importantly, I was able to continue school with my twin brother. I love reading, listening to music and stories, playing tennis and dancing. I have entered into my first solo ballet I Eisteddfod this year. I don't really know what it is like to be deaf, as I am always hearing with my cochlears, but I hate having them off when I bath or when I have to go for my map.
What a lovely reflection from a little girl who's experienced living with newborn hearing, well, who's experienced newborn hearing screening and has lived with profound hearing loss. There's a little baby as well in our audience today, a special guest actually. His name is little Abdullah Miles. And when he was born, he had profound hearing loss. He experienced newborn hearing screening. Today, he's a precious 6-month-old baby. But at the young age of 2 months, he experienced screening and was diagnosed and already has his first hearing aid. I'd love to chat to his mum, who will come up next, Mrs. Abdullah Miles. And I'm curious, Abdullah's mum, Ramiz, if you could share your experience around having a little one who had newborn hearing screening, how was this for you? And how did this impact not just you and Abdullah, but your entire family?
Hi, everyone. So Abdullah was diagnosed with hearing loss since the first day when he was born. And initially for the whole family, it was a shock because he's the first in the family from both my side and my husband's side as well. So with the support from the doctors at Baragwanath Hospital and family, we accepted it, and we've learned to communicate with him through the hearing aids and things. So we would like other people also to be aware of this, because initially for us, like, we thought that how are we going to be able to communicate with our baby? We're going to have to learn sign language and all that. But with the support from the hospital, the speech audiologists and things, there is hope that he is able to speak. And that is why we started immediately putting on his hearing aid, so that he is able to identify all the sounds around him, be able to laugh and listen to sounds, and to able to also learn from that sounds, so that eventually he is able to speak when he does learn to speak. So he is also, there is a possibility that he might do the cochlear implant. But as of now, we're just sticking to the hearing aids to see how he does cope with it. But for us as a family, we are coping with it with all the support from our family, our colleagues, and especially the doctors at Baragwanath, Dr. Atia, Dr. Sashni, Dr. Danny, and Dr. Shanae. If we didn't have the support of those doctors, I don't think we would have been able to cope as a family. But day by day, we are accepting it, and we are working with the doctors and everything, so that it makes his life easier, and for us as well, because he's still young. So he still has a lot of learning to do. And for us as well, we're learning every day about how to deal with it and how to carry on in life with this disability that he does have. Yes, so we would like other parents also to be aware of this, so that it makes it easier, because as young as he is, it would be better to do it earlier than later, so that they have a better chance of learning to speak and to grow up with this disability better than when you find out later, than when they already heard the sounds and things. So we are happy with how so far with all the progress that he has made with his hearing aids on. And yeah, as you can see, he is also a happy chappy. And he's doing well with his hearing aids as well. Yeah.
Thank you so much, Mum. Thank you. It's so beautiful to see him react to the sound of your voice and look at you. Maybe just one short follow-up question. You speak around things that you want other parents to know, other moms, and you spoke initially when we engaged around being stopped on the side of the road, and many people, see the device and ask, "How did you know?" Are there any questions people ask you or things you wish you had known, reflecting in your pregnancy or even
Yeah,
after birth?
people do ask how did we find out. And he was initially tested the first day when he was born, the hearing screening, and failed. 2 weeks later, he did another test, which also failed. Then he went to the audiologist for the sleep ABR test. And then people do ask, and all we can say is that, if it's better that we found out now than later. And also, it's there's no reason for it really, because none of us in the family has any family with a hearing loss and things. So it was God's will. We had to accept what it was, and just live with it and work with it every day.
You are doing an incredible job, and he looks like a beautiful little baby. And thank you for sharing that story. So many families may have children born with profound hearing loss, and it's not in the family. And so
Yes.
this is further the importance of why every little baby needs to be screened. But thank you so much for being here today. I'll take you off the hot seat for now, and we'd love to come back to some questions a bit later to see that precious face. But maybe now we move into some of the panel discussion, bringing forward the head of speech therapy and audiology at Chris Hani Baragwanath, Dr. Sarah Sadna Bolton. And Dr. Bolton, over to you to share a little bit about the newborn hearing screening, what it is, how it works, and thank you for that beautiful case study and story of little Abdullah and his mum.
Good afternoon, everybody. Can you see my slides firstly? Hi, can you hear me?
Yes, we can, and we can see your slides.
Okay,
Thank you.
perfect. Let's move on. Okay, thank you for the opportunity. And I think just listening to Abdullah's mom and seeing on screen just is a wonderful feeling for me to know that our team at Kirsani Baragwan Hospital was able to impact his life and give him a better start. I'm going to be focusing on a systems approach to early hearing detection and intervention, because I think it's quite important for us to understand that EDI doesn't exist in a silo. So in order to, sorry, I'm just figuring out how to move my slides. When we look at EDI, we also need to place it within the framework of early childhood intervention. And this is important because if we get EDI right and we're able to screen early, this supports early brain development. And as we know, the first 3 years of life are critical for brain plasticity and language development. Early identification also promotes communication and language and enhances cognitive and social development. It also improves educational outcomes, and research has shown that if intervention happens earlier, children can enter mainstream schooling and have much better outcomes than if they didn't. And very importantly, we need to work within a model that empowers families. So early identification allows families to know earlier and to be able to get the necessary help and support that they require, as indicated by Abdullah's mum. So when we look at a systems approach, it's important that EDI positions itself as an integral part of maternal and child health services. So I'm going to talk through each of these just to get an understanding of what this means. So when we look at integration into routine care, this is important that yearly screening is included as a standard part of newborn checks. So it's not a standalone. It should be available where babies are getting their vaccinations and weight checks and growth monitoring and so forth. We should also ensure that we integrate EDI within a primary healthcare model of health system delivery. And here we need to train people to be able to do the screening. So I know that nurses in primary healthcare already have a lot on their plate, but we need to look at healthcare caregivers who are able to engage in screening with the supervision and support of an audiologist. And it's therefore important for us to link whatever we do to maternal and child health programs. We need to incorporate EDI into routine immunization visits and well baby clinics. For timely diagnostic services to happen, and we're finding that at Barrow, that we are able to get to a higher percentage of babies now, but it also means that this is filling into our other systems. So if we're able to identify babies early through our screening, are we able to afford the necessary diagnostic services that they require? So this means that we need very clear referral pathways. So say, for example, if hearing screening is happening at a primary healthcare level, we need to ensure that within that cluster of service delivery that there is somewhere where the baby can refer for diagnostic services. We need to also keep to the defined timelines as established by screening by 1 month, diagnosis by 3 months, and that by 6 months, a child should be in an intervention and have the necessary device that they need. We need to integrate EDI into the health system. So it's not just the role of audiologist, it becomes the role of a hospital as well, or a clinic, or wherever you are, that everybody is rooting and ensuring that EDI happens and is available. We need funding and definitely policy support, which we don't have at the moment. And I think this will make it so much easier for us to convince our managers and convince programs that early hearing screening is an essential service and is a right of every baby born in South Africa. We need an adequate number of audiologists, ENT specialists to be able to ensure that the diagnostic services are carried out appropriately. And the workforce also needs to ensure that we are training primary healthcare workers, community health workers, to be able to do screening at community level. Infrastructure and equipment is really important, and we know that this is a challenge at many places where we really struggle to even get our equipment calibrated from year to year. So it's important that we establish systems that keep our equipment going so that we don't miss out on an important stage of a baby's life. Once again, I want to, within an ECI model, stress family engagement and support is important. We need to ensure that families are counseled and that they are given information in a language that they understand and using terminology that they understand. We know that the return to follow-up is a problem everywhere. So we need to ensure that we send out appointment reminders, that we include other levels of healthcare to be able to, maybe if there are people going into a family's home, to ensure that they ask, have you been for your follow-up hearing test and so forth. And important that in doing all of this, we reduce the stigma around hearing loss and the misinformation as well. Working within an MDT model is important. And when we talk about a multidisciplinary team, we need to center this around the family. A family needs to be an integral part of everything that we do from the start. And not just as giving them information, but also including them in the decision-making that is made around their child and their child's care. We need shared information systems, which we don't have at the moment. Many of us are still working on a paper-based approach, where we depend on a paper-based file that a family carries from one level of service delivery to the next. And we're hoping that we can have a shared platform that information can be shared across levels of services, but also across provinces as well. In order to function as MDT, we need to ensure that there's regular communication between team members, that we also have one person dedicated to helping the family navigate this whole complex system as well. And each member of the team needs to have very clear and defined roles and responsibilities. Monitoring and evaluation is really important because if we don't have the data, if we can't show the impact of what we're doing, it becomes very difficult for us to get sustained support, be it through financing or equipment. So we need tracking systems to flag children who need that diagnostics and ensure that we have better follow-up. We need to ensure that all MDT members track development outcomes and adjust interventions to suit the linguistic and cultural background of families and share information as well. We also need to come to a point where physiotherapists, occupational therapists, whoever is working with the child asks about hearing and refers appropriately. We need regular audits to ensure that we are meeting the targets from screening to diagnosis. We need data collection to identify bottlenecks. So what is it? Why are families not coming? Or why is it that there's such a lag between screening and diagnostic? So understanding what are the challenges that we face at different levels of healthcare. Together, we need to create a no-delay system where children move seamlessly from screening to diagnosis, and we reduce the risk of missed intervention opportunities. So very quickly at Chris Hani Baragwanath Hospital, we wrote a business plan around 2018 to ask for our hospital support in terms of getting more HR, more equipment, and better support for Eddie. But we were told that in the greater scheme of things, the hospital doesn't have a budget. We then went back to the drawing board as a department and looked at how is it that we can try and enrich more babies in our hospital without depending on hospital resources. And this is where ideas came around the table, and we then decided to collaborate with organizations outside the hospital. We contacted a recruitment agency who provided us with learners. We then trained them to do hearing screening. And over the past few years, with the African recruitment providing us with learners, as well as CHI providing 2 screeners over the past year, we've been able to move from reaching 3% of babies to now 43%. And in the past 2 months, we've got up to 60% of babies. And to just understand that we have close to 2,000 babies born at Barra each month. So we could only do this using a systems approach, thinking out of the box and using innovative ways to look at resources not only within our hospital, but it would be important that we have policy development and that we have screeners on our payroll as well, so that we're not dependent on outside funding where we have screeners only available for a year and then we need to train a new cohort of people. So if you have any further questions later on, Sashni, who's the audiologist leading the program at Barra, and I can answer any related questions. So thank you so much for listening.
Thank you. Thank you, Sadhna. I'm really so moved by that comment. We must all, I think what you said, we must all ask that question. Have you been screened? And if you have been referred, have you had the follow-up screen? Taking that systems thinking and integrated approach to make sure that we can innovate. Anyone can be part of the solution, not just government sector, private sector, civil society, mums and dads. So thank you so much for that. I'd love to now hear around what's happening on the ground in a different province. So we have a clinical audiologist, Mr. Sakile Nkosi, who's working in Mpumalanga as an audiologist and screener. We'd love to hear your reflections now having heard the policy and the purpose. What is happening on the ground with your screening?
I'm trying to share my slide. Okay, can you see my slide?
Yes, we can. Over to you.
Okay. So my name is Sakile. I am an audiologist at Mpumalanga, specifically Leidendorp Hospital. So the portion of my presentation will be more from a screener's perspective. And in this section, I will highlight the structure of the service delivery, the multidisciplinary team, common challenges, and also strategies to strengthen and sustain these services. And that will be drawing lessons from our current newborn hearing screening program at Leidenberg Hospital in Mpumalanga. And as already Dr. Sadna's, in Dr. Sadna's presentation, we could actually gather that it's clear that hearing screening is an entry point to early hearing detection. And from a screener's perspective, here newborn hearing screening, it's about daily routines, teamwork, and problem solving. And in Leidenberg Hospital, a high proportion of our screenings are done at community level, given the level of care that our facility is providing, and followed by our in-house multidisciplinary early intervention clinic, which is done by a variety of rehab professionals, OT, speech therapy, and physiotherapists. And also a smaller proportion of our screenings are done at maternity ward and also outpatient department. And there are two main newborn hearing screening strategies described in literature, one being universal screening and the other one being risk-based screening. And with universal newborn hearing screening, which involves testing every infant within the first month of life, is often considered the gold standard. But however, in a resource-constrained setting like ours in Leidenberg Hospital, a risk-based approach may serve as a practical starting point. That is whereby only infants who present with risk factors for hearing loss are screened. And in our context, to bridge the gap between universal and risk-based hearing screening strategies, what we've done, we've adopted an approach that we've actually coined ourselves to call it a blended strategy. And in this approach, we ensure that services are not denied to any infant and screening is voluntary, and the services are available to mothers who even delivered outside our facilities but became aware of the service through awareness or word of mouth in the community. And with regard to the tools that we use, we currently use distortion product autoacoustic emissions and automated auditory brainstem response as screening equipment to conduct our screenings. And our testing protocol begins with an OAE screening. And if a referral result is obtained, the infant is scheduled within 1 week for a repeat DPOAE testing and AABR. And if the results are still indicating a refer, then the infant is referred to a tertiary hospital for further diagnostic hearing assessment. And following diagnosis, intervention is initiated in our facility. So for newborn hearing screening to be a success, we need to always adopt this African proverb that says it takes a village to raise a child. So meaning that raising a child is a community effort that requires positive involvement of many people, including the parents, family, neighbors, teachers, to provide a nurturing and supportive environment for the child's healthy growth and development. And in our program specifically, there is a great deal of collaboration with other team members, both professionals and non-professionals. And in our newborn hearing screening, we have 2 audiologists who provide the screening on rotation basis. Then we have the most important members, which are the parent, or we would rather say the family, as they are the advocates of their child and also the voice of their child. And we have the nursing staff who are advocating for the service in postnatal ward and also assist us in facilitating referrals, especially when the screenings are done at PHC level. And within our multidisciplinary clinic, we have the speech language therapist, occupational therapist, and physiotherapist who are also assessing other domains of development, such as communication and motor development. And for our high-risk infant, we also refer them to medical doctors, or sometimes they become part of our clinic on the day of screening to monitor the overall health of the infant who present with other additional risk factors. Our daily work is often shaped by systemic and contextual challenges, and in our newborn hearing screening program in Leidenberg, the following are challenges that that we encounter and are consistent with other challenges faced in other South African public healthcare facilities. So first being patient to healthcare provider ratio, and generally speaking, there is scarcity of healthcare professionals and the impact is felt greater in rural settings, and that often affects service delivery and also implementation of programs like newborn hearing screening. And loss to follow up is our biggest hurdle. So is the most significant point of failure in our newborn hearing screening, and these reasons include geographic and transport barriers. So a huge of our caseload consists of patients who live in the surrounding farms and plots as far as up to 80 kilometers from the hospital. And these areas are often characterized by scarcity of transport, and they rely on private transportations, which are very expensive. And one patient mentioned that it cost them around about 450 rand to hire a private transport to come to the hospital. So then at that point, they need to prioritize, must we spend the last money we have just to go for newborn hearing screening follow-up appointment or not? And another factor that contributes to the loss to follow up are socioeconomic factors, that parents may not be able to take time off work or prioritize follow up due to pressing survival needs. And in the case of Lydenburg, most mothers are farm workers and domestic workers, and they reside at work and return home on off days. So this contributes a lot to the non-compliance to follow up. And we've realized that a lack of understanding also contributes to loss to follow up, where despite counseling, the agency of a refer result may not be fully grasped at that time. So one testimonial from a mom says, but I don't see anything wrong physically with his ears. So then that means they didn't understand what a refer result could mean. And also mobile populations, we are at the border of two provinces, and most families may move between provinces or back to rural homes without a clear transfer of record. And also poor data tracking system, where we don't have any digital form of tracking data system, but relying mostly on paper-based, and also calling moms and SMSing them, of which they really get the message on time. And also another challenge that we're facing generally in Mpumalanga is equipment and infrastructure. Equipment that is unreliable, lack of calibration, and also power outages that we often experience also in our areas like in rural, can disrupt the service. So in 2024, when Chai approached us to set the newborn hearing screening, we conducted an informal survey in Mpumalanga to determine which hospitals are actually rendering newborn hearing screening services. And we found that 90% of the hospital cited lack of calibration, lack of equipment as major contributors of not implementing this service. Another issue we have is competing health priorities. In a context like South African public healthcare, where we are dealing with high prevalence of HIV, TB, and malnutrition, so hearing screening can be perceived as a lower priority by healthcare managers. And most of the attendees in this webinar, I'm sure they can attest to that. Especially when you're advocating for budget, it's often diverted to life-saving programs. Despite the challenges, there are, of course, clear actionable strategies to build a resilient system, and that can be achieved by a number of things. We could also look at strengthening the core service, and under strengthening the core service, we could explore task shifting and training, which is to train dedicated screeners, could be enrolled nurses or community healthcare workers to focus solely on screening and reducing the burden on audiologists, especially in the case of rural where there's only one or two audiologists covered in a large catchment area. And we could also look at standardizing our protocols and tools, and that we could actually achieve that by implementing national protocols for screenings, follow-up, and data management, and also develop visual aids and counseling flip chart in multiple languages. We could also explore robust data systems, such as implementing a web-based tracking system to monitor every baby from screening to diagnosis to intervention. And of course, SMS reminders for appointment can also be highly effective. And in terms of improving follow-up rate, we could explore this by point of care solutions where possible, use AABR for initial screen to reduce false positive results and the need for rescreen. And we could also look at mHealth clinics, which is mobile health, such as deploying mobile clinics equipped with screening and diagnostic ABR to reach rurals and underserved areas where follow-up testing. And we could also utilize the presence of community healthcare workers to assist us trace families who miss appointment and provide community-based support and education. And under advocacy and sustainability, we can look into integrating our services with primary healthcare, such as maternal and child health initiatives, and also immunization clinic, and this will actually assist us in creating multiple touch points. So to conclude, as a screener, we are custodians of the child's auditory world. The challenges in South Africa are real, but they are not insurmountable. By working effectively with our multidisciplinary team, advocating for robust systems and employing innovative strategies to combat loss to follow up, we can ensure that where a child is born does not determine their ability to hear, speak, and thrive. Our commitment turns a simple pass or refer result into a lifetime of opportunity. Thank you.
Thank you, Sakile. It is so encouraging to know that, yes, there are realities, and those realities aren't so different across the metros and the rurals. The loss to follow up is a recurring challenge that also Dr. Bolton raised at Barra, and that you managed to also surface in Mpumalanga, even though, of course, there are nuances, and we must appreciate that EDI and newborn hearing screening in terms of process and policy may look a bit different in different regions. But something I'd like to also just surface that is so powerful is how you echo the need for the screeners to diversify. It doesn't just have to be an audiologist that's a screener. In the comments, we have a question around, can gogos, also be worked with as caregivers? And yes, anyone can be a screener. The Health Professionals of South Africa, the HPCSA, the Health Professional Council of South Africa, they recommend that any designated person who's been trained in screening can be a screener. It's been seen in literature, and it's also in practice. In the Western Cape, screeners may look like a mom. We have screeners who have babies who have previously been diagnosed. We also have screeners who are rehab care workers and function similarly to community healthcare workers, and some screeners are even nurses. So, really everyone can be part of that multidisciplinary team. This being said, it'd be an important position for us to stop, reflect on what we've heard, and think through, what does this mean for the country? We've heard examples from a mom, from different provinces, but what does this mean nationally for us? And what is the opportunity? I'd like to now bring in Dr. Busisiwe Ndlovu, who is the Director of Non-Communicable Diseases at the National Department of Health. Doctor, I note that you're coming on call. If you'd lean forward slightly for us so we can see your face, and please share with us your closing comments in drawing a picture of where South Africa seeks to find themselves in advocating and positioning AD as a priority.
Good afternoon. Are you able to see me now?
Yes, perhaps tilt your camera up slightly. Yes, that's a bit better. Thank you.
I don't know what's going on with my network, and I see it's like a bit fuzzy.
Perhaps, although we haven't been able to see your face, would you like to do a closing comment, maybe with video off, then we get to
Okay.
hear your comment. But we are so sorry we haven't been able to see your faces clearly with the virtual
Oh
background.
my God, I don't know what's going on here. I don't know whether it's the camera or something else, but nevertheless, okay, let me just do this and talk to you. Colleagues, good afternoon, and thank you very much for affording the department this opportunity to join this very critical meeting. So on behalf of the National Department of Health, really, I feel very honored to be part of the discussion on the newborn hearing awareness. And then I'm also grateful to our partners, Hold My Hand, Chai, and all the stakeholders for convening such an important meeting. For us here as the department, hearing is a cornerstone for the child's language, learning, and social development. The undetected hearing loss in the early years can be very much irreversible, and it can limit the educational status or even for a child to achieve in his or her life the employment opportunity, and even it impacts negatively on the quality of life. So when a child has got these limiting effects, he cannot reach his full potential. And we see that the burden in the country and globally is very huge. And it indicates that more than 34 million children live with this disability of hearing loss. And these are coming from countries like ours, which is South Africa, and even other African countries. So it is estimated in South Africa alone that 6,000 infants are born with a hearing loss. And I've heard from the previous speakers on what they've indicated. So it is about 17 children every day, that get diagnosed with a hearing loss. So despite the significant impact hearing loss has on the children's learning outcomes and their well-being, most children with hearing loss are not identified quite early before they can even reach school. So this affects them, and it has got a bad impact because their brains are less sensitive to the language and numeracy. So as a result, the interventions are less effective and most costly over a long period of time. Some of the consequences of late or non-intervention will include a child getting a delayed speech or a language development, poor performance and poor learning outcomes, increase in the risk of social exclusion and being stigmatized. Then it also impacts negatively on the financial strain of both of the family and the community. So global community has recognized this challenge through the World Health Assembly resolution on prevention of deafness and hearing loss during 2017. Then also the commitments under the SDGs, Sustainable Development Goals, particularly on the universal health coverage and the inclusive education. The WHO report on hearing calls for prioritization of early identification and intervention. So here in South Africa, as the Department of Health, we are committed into integrating the ear and hearing care services into primary health care services and also in the maternal and child units. And this will include strengthening newborn and infant hearing screening programs across, expanding access to audiology and speech therapy services, collaboration with all the provincial health department, even the academic institutions, to build a workforce capacity, meaning that all our universities where health faculties or health sciences are there, we need to strengthen this so that we make sure that all our healthcare forces which are in this space are more capacitated. And also exploring the partnership to make hearing technologies, including hearing aids, cochlear implant, which must be made accessible. And thanks very much to Chai for continuous support through and through with ensuring that all our children, get support, and even other partners, as I have mentioned before. As we highlight the deaf community this month and the need to screen all newborns for hearing during this Deaf Awareness Month, I want to put more emphasis that we need to conduct screening early, and we detect early so that we are able to intervene as early as possible and to save the children and their future, so that most of the children receive the right support at the right time and they are able to thrive academically, socially, and economically. So I encourage all of us in this platform and beyond, the health professionals, educators, policymakers, the civil societies, our partners, to advocate, innovate, collaborate, so that no child is left behind due to hearing loss. Thank you once more to all the organizers of this important meeting for prioritizing this critical issue. And I'm looking forward to continuous work with all of us to ensure that every child has a right to hear, learn, and thrive in his or her own life and improve the quality of life. Thank you very much. And sorry for my screen.
Not a problem, Dr. Ndlovu. I think your words were so important and those were fully audible. And yeah, just echoing that call to, for every person on the call, no matter what role you have in the life of a child, to ask for assistance at your local facility. As you've heard from Dr. Ndlovu, this is a priority in national government to ensure errors can be screened. I'd love to now spend a couple of minutes engaging with you. You've listened to us, and thank you for your time. But in the true essence of communication, one must serve and return and take time to listen. And so when I look at the comments, there's so many questions coming in from Jane Simmons, from Go. We also have a question coming in from Samantha Adams around screening. How does one become a screener? We've spoken a lot around screening being, part of everyone's responsibility, from asking the question if one's been screened or to doing the screening themselves. And I see Dr. Bolton has replied in the chat, so please go take a look at that comment and response. There was also some discussion around screening and the critical next steps. We've discussed a little bit about the multidisciplinary team, but we know, what does it really mean once we have screened? What are the next steps? Dr. Ndlovu has spoken about the technology needed, but what about the world where there is no technology and young families or young children begin to sign? What does early intervention look like? And I see a comment from Prof. Claudine Storbeck. Prof, I wonder if you wanted to allude a little bit to what happens after screening. What does this multidisciplinary team look like? Really opening the floor for you to expand on your comments.
Can you hear me?
Yes, we can. Thank you.
Wonderful. Thank you for that. I just wanted to make sure that we always remember that we're screening newborn babies for two reasons: to get amplification in place, whatever the technology is, and the therapies and support that's needed. And number two, to provide families, no matter their race, their gender, their culture, where they are, rural or urban, the early intervention support that they need for their unique child. So it's usually a more medium-term plan for the family to provide them answering their questions, giving them knowledge and skills, and all the support holistically that they need, which forms part of that multidisciplinary team that Dr. Sadhna Bolton spoke about. And it's typically at no charge to the family because it's a human right, and in the family's home language, and ideally in their home, so it's convenient for them. So for us to remember, family-centered early intervention is part of that longer-term journey as we then help prepare families for this, being a parent of a child with a hearing loss and preparing them for school.
Thank you so much for that, Prof. Thank you for really, just holding the space for us to discuss about the care cascade. And maybe taking this time also to to reflect on, thank you so much, Prof, to reflect on the earlier conversations we had around early hearing detection and intervention being an entire pathway. Although this month of deaf awareness, we are advocating for the screening aspect, which is a critical, important start. We know that's just the beginning of a young person's journey. Well, let us not forget, but rather let us remember that this is really not the end of a conversation. It's just the start. And it's the beginning of more than just conversation, the start of listening, reflecting, and then action, but collective action. Today, you've heard from a special guest, little Abdullah, with his mom as the proxy. You've heard from Dr. Sadna Bolton, who works in policy and is leading a unit at Barra. You've heard what it looks like in a more rural area from an audiologist. And then you've also heard from a leadership perspective, where our country is going and this being a priority. So I implore you as a gogo, as a mom, as a caregiver, as a strategist, I see so many different roles on the call, whether you're in South Africa or outside, to think about what your contribution is and how you can play a part in the care cascade for Eddie. We believe that every child lives on the edge, either the edge of possibility or risk. And wherever they go is dependent on the choices that we make, and we all have the responsibility to support them to reach their full potential. At Hold My Hand, we believe that it depends on the whole of society to move forward. And so I'd like you to know, thank you, that this is an important part of the work we do. And you'll be able to come back to this, you'll share the recording. Wanting to thank you for your time today. Remember, this is a webinar series. There will be another one that will follow on the 13th of November. We'll shift our gears to a slightly older group, and this time we'll be speaking about teenagers and identity and adolescency. So, thank you so much. Remember to leave your details in the chat. This will be recorded, we will share it. And thank you so much for making the time to listen to the silent crisis. Keep well.